The COVID-19 pandemic was a stark reminder that the greatest threat to humanity has come from the tiniest of creatures, disease-causing microorganisms. Especially since settled agriculture and the domestication of animals, microscopic pathogens have been a singular cause of human mortality, wiping out entire ethnic groups and claiming more lives than wars, natural disasters, and non-infectious diseases combined. They have shaped world history, extracted colossal economic costs. But infectious diseases are feared not just for these devastating consequences, but for their stealthy, silent mode of transmission. Practically invisible disease-causing microorganisms can migrate undetected, even across ever more tightly controlled political borders. And yet, even as borders cannot keep out infectious diseases, they have historically structured our vulnerability to them. Polities with similar epidemiological, socioeconomic, and demographic conditions have varied starkly in their control of contagion. Why? This is the central question of my book manuscript, Moral Vaccination: How Ideas and Institutions Controlled Contagion in China and India in the 19th and 20th centuries. This is a project that began well before, but has taken on a new importance with the COVID pandemic and with growing research that shows how climate change is intensifying our vulnerability to new and existing pathogens. Epidemiologists warn that the next pandemic is not a doomsday scenario. It is inevitable, even imminent. As the title of the book indicates, I focus in on the question of the control of contagion through the dissemination and uptake of vaccines, which have been the single most important intervention in public health. Since their invention, vaccines have been the single most effective tool in controlling infectious diseases, and just in the past 50 years, they account for 40% of the observed decline in global infant mortality and have led to over 10 billion years of full health being gained. And yet, over the past couple of decades, there has also been a worldwide rise in reluctance towards and even a refusal of vaccines. Vaccine hesitancy has increased in intensity and scope to become, by the estimates of the World Health Organization back in 2019, one of the top 10 threats to global health. Public health experts estimate that each year vaccine hesitancy causes 1.5 million excess deaths globally. It has prompted the resurgence of potentially deadly diseases, measles, mumps, polio, from communities in Latin America and Asia to Europe and here in North America. And it continues to snarl global efforts to control COVID-19. So how do we control infectious diseases through vaccination? Through state commitment to vaccine development and dissemination, through effective frontline implementation of vaccination programs, both every day and during public health emergencies, and critically, how do we control contagion through vaccines by encouraging their popular uptake? Because even the safest, most potent, most equitably distributed, and easily accessible, safe vaccine is only as successful as people's willingness to adopt it. I explore this timely, urgent, and vexing question through a historical lens by focusing in on the world's first and quintessential vaccine, variola vaccinae, which gave rise to the term vaccine itself, and targeted what most medical historians will say is the oldest and deadliest viral malaise to affect humanity, smallpox. And specifically, I undertake a comparative historical analysis of the very different experiences in controlling smallpox in China and India. So towards maximizing causal inference, I'm a political scientist, I structure 3 sets of paired case comparisons in India and China at different units of analysis across the temporal landscape that is marked on the one hand by the discovery of the vaccine in 1798 and the global eradication through the dissemination of this vaccine in 1975. And so across this time period, the invention of the vaccine and the eradication of smallpox, which is the only human disease to as yet be eradicated, I compare the cities of Canton and Calcutta, I compare provinces within India, and then I compare the sovereign states of China and India from the 1950s to 1975. And this multi-sited archival research across these case comparisons allows me to see the shortcomings of hegemonic rational actor models that would explain the control of contagion through understandings of humans as strategic interest maximizers. So what do I mean by that? So for example, a rational actor understanding would say that states would commit to the health of their population only or primarily because it advances their pursuit of political power. And so they focus, for instance, on public health campaigns because they fear that a lack of commitment to health and the control of contagion might mean that they're punished at the ballot box, or that the frontline bureaucracy, healthcare providers, nurses, community health workers show up to faithfully carry out their job because they're enticed by monetary incentives or by the fear of sanctions because they are surveilled and punished by their superiors. Or similarly, that people adopt vaccines as a result of coercive sticks, so fines, potentially even imprisonment, the denial of access to public services, such as your kids' ability to attend public schools, or because they're incentivized by carrots. Think of all the freebies, donuts, coffee, lottery tickets that were offered to Americans to take up the COVID vaccine. Or they adopt vaccines because they think rationally about the risks of the side effects. They weigh these against the benefits and make a strategic calculation. In contrast to such a rational actor model of thinking, I build on a vast, if scattered, body of scholarship across political philosophy, neuroscience, biology, psychology, sociology, and economics that shows that humans are not just rational utility maximizers, they're also critically moral actors. Legions of labs, survey, and field experiments, as well as sociological and ethnographic studies from different parts of the world, have shown how humans are driven by a wide range of non-pecuniary moral motivations, whether that is emotions, empathy, fairness, reciprocity, or a range of worldviews and cultural schemas and values. I build on this scholarship to put forward a moral framework for the control of contagion, showing how political leaders' decisions to commit to public health, the control and implementation of these policies by the frontline, and people's decisions to vaccinate or not are best understood as embedded within a moral relationship between states and societies. Thus, the title Moral Vaccination. And to learn more, you'll have to wait for the book.